refreshing change for all of us that he is going to speak not much with slides. So you can start now.
Thank you.
You'll get 13 seconds.
Okay, thank you. What is your scheme? That's the first question most of the community members ask our team members when we enter the communities. I mean, what it implies is that what are you going to give us? Are there any? Are you here for farm loan waivers? Are you here to give us some direct beneficiary transfers? Are you here for conditional cash transfers? These are the questions which my team members are perplexed with. I mean, they have no answer for that. Even I don't have an answer for that. And they come back, and when they tell me, I say, explain them that we are here for health benefit. I mean, we are here for a health program and a research program. And when they say that, we have blank faces in the communities. The theme of this conference is psychiatric rehabilitation moving beyond the walls. Things are very difficult beyond the walls. It's not very easy. It sounds very exciting, but when it actually boils down to beyond the walls, it's a very scary world. It's a very difficult world. And as Dr. Jain and Dr. Sareen alluded to, within the walls is not that kind of a scary thing. There are good things within the walls, and then there are difficult things beyond the walls. Namaste, I'm Rahul Shide. I'm Professor of Psychiatry and DBT Wellcome Trust India Alliance Fellow. My primary work is in the field of community-based mental health programs and community-based research. Uh, I must say that I have not worked in the area of severe mental illness or community rehabilitation, and I'm here only because of my dear friend Dr. Jagdish, who thought that I would be a good person to be part of this symposium. Otherwise, this is less of severe mental illness things, and it is more of depression, drinking problems, and my current work, which is around yoga-based intervention for antenatal depression in rural Maharashtra. So this is the only slide which I have for today, and I'm actually preventing some deaths by PowerPoint. All that you need to know is my email ID, which is in the right hand corner. If you are interested in some of this work, you can write to me, or you can look at some of these links. These are not hyperlinks, but then there are enough amount of references over here. So on right hand side is the program which I co-led around 10 years ago, 12 years ago. And on the left hand side is a program which I'm currently leading. So one is a community. So Vishram was a community mental health program which focused on drinking and distress and drinking problems in eastern part of Maharashtra. And the second one is a pragmatic randomized control trial which we are currently doing in western part of Maharashtra. So what I'm going to talk about today is based on all that, what is there in these programs, the learnings and experiences I have from these programs. The reason I've decided to use this particular format is I thought it's actually good to deliver a talk that you always wanted to hear. Paraphrasing, writing a book that you always wanted to read. I mean, my mentors did teach me a lot, and there was a lot of things which I heard from them. But I thought someone would have explicitly told me about some of these things, which I'm now going to enlist in next 12 odd minutes or so. So let's come to what I want to present today. So the first thing is, this is the question: what is the scheme you have? So in the current state of affairs, well, welfareism is kind of increasing. Every state has some or the other benefit schemes going on. So when our teams enter the communities, this is the first kind of thing which people ask us, that you here for, because we have forms and we have got data which we collect. So people think that this is some kind of an agency which is helping governments to kind of implement their programs. Very recently in Maharashtra, we had a beloved sister, or Ladki Bahin Yojana, and that had a huge impact on the kind of work which we're doing. So everyone thought that we were part of that team. And if we were, when we said that no, we are not here for Ladki Bahin, then they said come after a month or so, because we are very busy enrolling, and the entire system was actually, the Anganwadi workers and the community health workers and everyone was busy in enrolling and getting all these women on board. So that's the first challenge. So then how do you enter the communities? How do you establish yourselves? I don't have answers, but I have some experiences and learnings. So what we thought was to establish ourselves in the community, especially for a small research team working within a medical college sort of a domain, or working with a with a research NGO, it is difficult. If you are partnering with established non-governmental organizations or established community-based organizations, it's a different thing. So let's say for Samagram or the earlier programs, the Banyan. But for a small research team, this is a very difficult thing. And so my target audience today is someone, an early career researcher or early career program person who wants to enter into the field, a mid-career person who is facing this challenge. I want to share these experiences with them. So what we thought was, let's connect with influencers in the community, not those virtual influencers, but actually people on ground. So let's say in the domain of women's health or pregnancy or antenatal care, for us, Anganwadi workers and Asha workers are the point of contact. So we sort of start engaging with them. We have initial discussions with them. And we kind of notice that for first 2 to 3 discussions, everything is great. They want to help us because we are doing great work. We are doing lots of service. So they want to be with us. But over a period of time, they slowly start asking, what is there for us? In this program, what is there for us? I mean, what are we going to be benefited from? So slowly we then started realizing that only most of the times we don't have those monetary benefits to give to Ashas, especially when you are running a program which is not part of the government program. What we did was we started, for this yoga-based lifestyle intervention program, what we started doing was we started organizing yoga sessions for Anganwadi workers and Asha workers, with an idea that you basically are part of the community, you have your own problems, let's do a program for you. So based on those yoga programs, I think that changed the world. We stopped talking about our programs, and we started focusing on, let's focus on you. Let's take your health as a priority, and let's start working with you. So Anganwadi workers were then on board, and they said, I think you are really doing a good work. So let's kind of collaborate and let's do something together. The next step is, through them we start inviting women to our programs. And when we start inviting women or other community members to our programs, again the question arises, the third question, for what? For what you are inviting us? And when we say that, no, we have this nice DBT Welcome Trust India Alliance program and we are collecting data and we are going to do a randomized control trial, that's a non-starter. No one cares. No one cares about your research, no one cares about your RCTs, no one cares about your programs. So then how do we actually then convince them to come for whatever we want to do with them? See, one thing is Anganwadi workers can call pregnant women and they have to come to Anganwadis, but that doesn't always work. So then we said that let's shift the focus. Let's do something which is like a workshop or like a program, and we called it as Anandi Matrutva program, so joyous pregnancy. So the idea was that let's talk about something which will make you happy. And again, this is all work in progress. So what we felt was, with this particular focus, that let's join to kind of start talking or start discussing about what makes you happy or what will make you happy, and then we will see whether whatever happens with our program. So through that, we are now able to actually get a lot of women or a lot of community members interested in the kind of work we want to do. So they start coming for the program. Once they start coming for the program, again, if we start talking about depression, anxiety, stress, and all the sort of technical stuff, then the lingering question is, are you interested in what actually bothers me, or are you interested in your stuff? My experience with most of these mental health manuals, mental health training programs is that when we start talking all this academic language, people lose us. They start off thinking, are you interested in my problem? So our next step was to actually then focus on asking them the simple question, what bothers you the most? We were interested in depression, but what bothers women the most is that their most common problem was irritability, anger. This is something which I had never thought of as a researcher or as a person, but they said that our most common problem is irritability. For pregnant women, our most common problem is anxiety about what will happen, how this whole journey will happen. What will happen with the delivery. Their other simple problems were backache, low backache, and body ache and fatigue, and some family conflicts. So we then again started focusing on, okay, these are the things which you are interested in. Let's start thinking about these things and then move forward. So again, that works. Some of the women get on board and they are part of our program. Once they are part of our program, once they enroll with us, once we start intervention delivery, the next what the heck? I mean, why are you constantly calling us? You want to do 3 sessions for us. You want to have these all baseline assessment, 3 months post randomization, 12 weeks. This is a lot of burden for us. So again, we have to sort of manage with their own, I mean, whatever they think is possible, feasible. Many a times we have to do home-based sessions. I mean, most of our work is Anganwadi based. And what I'm talking about, yoga also applies for most of the behavioral interventions. So we can't really say that this is exactly we will do home based. No, that's, I mean, you have to do home based, you have to do Anganwadi based, sometimes you have to do facility based. So there's no one model fits all. Again, as what Dr. Jain alluded to us earlier in his talk, that there's no one right thing. So there are different ways of intervention delivery. Sometimes the mother-in-law is interested in what you are teaching, what you are talking, what you are not talking. Some women do have autonomy, some women do participate in whatever we say. So intervention delivery is not an easy task, especially even for those who are delivering the intervention, because for them also it's a huge challenge. They are not used to sort of adjusting with the tantrums of people who are part of the program, but then you have to. And finally, my final what is, what works? Well, I don't have an answer for that, but there are some things which we have written in some of these papers. So in Vishram program, what we found was that based on all these community-based programs, small group meetings and one-on-one psychosocial rehabilitation, psychological healthy activity program delivery, some of these things do work. We were able to establish that our program was effective in improving the contact coverage, which was, let's say, contact coverage is a technical term which I won't go into the details, but it improved contact coverage by 6 folds. There was also improvement in mental health literacy. These were repeat cross-sectional surveys with a population of around 100,000, 1 lakh population. So very quite a robust sort of evidence to suggest that some of these community-based mental health programs, I mean, some of the components are really helpful, and they can improve contact coverage. We were not able to sort of really establish whether there is improvement in effective coverage, because as I said, there are issues with intervention delivery. And based on that, we have created this kind of a toolkit. Toolkit was not such a bad word a few years ago. This was done 6 years ago, but nowadays toolkit has a different connotation. But now this particular toolkit has sort of details of those programs. It's available on Sangat website. And my work in the field of yoga research is a bit preliminary. And what we have done is we have done feasibility studies, we have done acceptability studies. And what we have tried to do is, to be very honest, we have written a lot of challenges which happen in delivering some of these programs, what kind of issues people face in the communities, what kind of issues we face as researchers working with the communities. So all this is available for you. I'll summarize now. Basically, moving into the community is not an easy task. It starts with you are competing with the state, with a lot of welfare benefit schemes, and people are looking for direct benefits, direct financial benefits, to convince people that no, basically health is also a good thing. You can focus on your health. There are health benefits, there are benefits of research, knowledge generation is an important national activity, and all that. I mean, people although won't understand, but it's important to kind of move ahead with that. One has to actually look at what is there for everyone. So even I have to take care of my own team members. I mean, other than publications, what is there for publications and the salary which they get, what is there for their own personal development, how it's going to help them. Beyond that, moving on to individuals, what bothers them the most is an important thing. And finally, for the research community, is important to tell that what works. I mean, otherwise there is a lot of anecdotal stuff moving around. There are a lot of experiential stories and things like that, but we also have to quantify. So thank you so much for patient listening. You gave me 13 extra seconds. I saved 1 minute from your time. And thank you so much for being a good audience. Thank you.
Thank you, Arun, and thanks for the presenter.